welcome everyone. Can people out there hear me okay? Great. So welcome to night 2 of the Connected 2025. My name is Nathaniel Jellinek. I will be facilitating tonight. I ask that as you join us and you have questions, you use the Q&A tab at the bottom of your screen, and we will have the final 10 or 15 minutes to answer all those questions. So please, when they come up, add those in. We're going to piggyback on what we heard last night. Last night was a really thorough background on the medical portion of TED, the disease pathogenesis, the disease course, how we're understanding the evolution of that disease now differently, and what goes into that disease in terms of risk factors, et cetera, and then pivoted into therapeutics and a really stimulating discussion on past, current, and future therapies. And so I think for folks who didn't get to see that, I urge you to check that out online at some point in the future. Tonight, our topics are TED conversations and story. And specifically the first hour, the conversations that matter. And we're joined by an esteemed panel of TED patients and TED physicians. We're going to have a discussion about navigating these conversations, interactions while working through the diagnosis, workup, and treatment of TED. And so briefly, I'll ask for each of our panelists to, in about a minute, introduce yourself to the audience, and then we'll get into our conversation. So we'll start with Betsy. Can you introduce yourself, please?
Sure. Hi, everybody. I'm Betsy Fader. I live in New York City. I'm relatively new to the Graves' disease and TED arena. I was diagnosed on my 60th birthday 2 years ago with Graves. Was diagnosed with Graves' disease. My doctors all suspect it came from COVID, which I had just a few weeks prior, and then a year later was diagnosed with thyroid eye disease. I work in the field of philanthropy and used to be a competitive Ironman triathlete until double vision stopped me from being able to ride my bike outdoors without having to close one eye to see where the road is going. So yeah, really happy to be part of this community. Not happy to have TED, but really happy to have connected with some very helpful allies and friends, and a lot of wonderful research and contacts through the TED community organization.
Thank you. Joe, can you introduce yourself, please?
Sure. I'm Joe Laverty, and I am a TED patient diagnosed in October of 2023. Just to clarify, the eye patch is not part of a Halloween costume that I decided to keep. I have very severe double vision and have to use that. I have been fortunate to connect with the TED community and Nathaniel in particular, and very honored and excited that he invited me to join everyone tonight. And so just looking forward to sharing my experiences and with everyone and learning more about TED, which is my goal every day, learn more about it.
Thank you. Dr. Rubin, can you introduce yourself, please? Yeah, you're muted.
You're muted. Peter, you're muted.
Hello there, I'm muted. Okay. I'm Peter Rubin. I'm an oculoplastic surgeon based in Palm Beach Gardens, Florida. I've been in practice for 35 years, with managing TED patients for 35 years. There's been a huge evolution in our management, but some of the same problems exist, and we look forward to working with you and coming up with solutions. Prior to being in private practice, I was the director of oculoplastics up at Harvard for 13 years, and I look forward to participating in this panel.
Thank you, Dr. Rubin. Dr. Weinberg?
I'm David Weinberg. I'm in private practice in Concord, New Hampshire. Like Dr. Rubin, I've been practicing for about 35 years as an oculoplastic surgeon and neuro-ophthalmologist, both in the academic arena and in private practice. Dr. Rubin and I both take care of a lot of TED patients, and it's a challenging and gratifying group of patients to work with, and some of the more challenging patients we see. And it's my pleasure to take part in this seminar.
Thank you, Dr. Weinberg. My name is Nathaniel Jellinek. I sort of bridge the gap here. I'm both a physician and a TED patient. I've been a physician for 25 years and a TED patient for 3+ years, and we're like the double vision crew of TED patients here. All of us have that as a predominant feature. I would want to start by asking Betsy and Joe, how do you go about finding the appropriate healthcare provider to help you with TED? And then as a sort of part B to that question, how do you prepare for your first visit with that TED provider?
Go ahead, Betsy.
Okay, I'll take a first crack at this. I didn't know as with many people, I didn't know anything about thyroid eye disease before I received my diagnosis. I got my healthcare provider through my endocrinologist. And, I can't say that I feel like I have found exactly the right TED specialist for me. I often feel like I'm taking up too much of his time. He doesn't have enough time for me. He's always in a hurry, and he's highly, highly recognized in the field. And I know he's, done some great work, but as a patient, I feel like, man, I have to come into this 15-minute appointment with all of my research done. I show up with a notebook. I show up with a pen. I have my list of very specific questions written out, and I won't leave the chair until I have at least attempted to get answers to my questions. Yeah, but I don't know that I'm going to stay with my current TED specialist. I might be moving on to somebody else who doesn't make me feel guilty for having questions and needing someone who doesn't minimize what I'm actually going through with double vision. So it's a hard journey. Yeah. I think, as I said in my bio, I live in New York City, and it's full of amazing doctors, but getting in to see these doctors is a real challenge because they're backed up, and often there's a long wait to get into the office.
Yeah. Yeah. And I know that those same challenges are going to be felt by Doctors Rubin and Weinberg, because they're on the other side of it and feel a lot of the same pressures. Joe, how about you? When you got these symptoms?
Little bit different. I am with Kaiser, so I was given particular doctors. One of the good things about Kaiser, though, is if you're not really happy with that particular doctor, they're very open to switching. And I view it as a journey that you're taking with a team of doctors, the oculoplastic surgeons, which we have obviously 2 here this evening, ophthalmologists, endocrinologists, and so forth. And I guess I would say to patients, TED patients, as you're going on that journey, on a journey with people that you respect, that you believe in, that you trust, because that is fundamental, that team is willing to talk to one another and so forth. And I think one of the biggest things is just go with your gut. If you're in there with them and it just, as Betsy was saying, you feel rushed or whatever, that's not a good feeling. That's not something that's going to make you want to follow what this doctor is saying. So, for me, I've changed the endocrinologist one time. I also think it's important, as you meet with any of the doctors, that you are open to talk to them about second opinions. And all of the people, I mean, in Kaiser, I got a second opinion from another Kaiser doctor. That second doctor recommended an outside oculoplastic surgeon that that I could go see. So I felt very good about not only their knowledge, but their openness. And probably the last thing is that they're willing to work as a team. Not that one of them says, oh, well, I really don't communicate with the others. It's important that they all communicate and that you feel that you are a team working to address this disease.
Mhm. Yeah. Yeah, and I want to bookmark the second opinion subject because I think it's important, and I'll be curious to hear Drs. Rubin and Weinberg's opinion on that. But just sort of flipping the same question to Dr. Rubin and Dr. Weinberg, from your perspective, how do you approach these first few visits? Both from, what are you hoping to accomplish, and what can patients do to sort of set themselves up for success with those visits?
Go ahead, David.
Well, it's definitely, we recognize that thyroid eye disease patients have very complex issues. And you probably want to be with an oculoplastic specialist who has an interest in thyroid eye disease. We understand that patients with thyroid eye disease have a higher complexity of disease. There's going to be a lot of questions, a lot of education, a lot of discussion. And it is important that the clinician take their time to answer all your questions. And as Betsy pointed out, being as proactive as possible in terms of thinking out your questions in advance, just to try and streamline it, because there is going to be a limited amount of time, unfortunately. As Peter and I have discussed with Dr. Jellinek, we did develop an automated questionnaire to take a medical history in advance. And the purpose of that is to streamline the visit to allow you more time for discussion. So it's an online questionnaire that can be completed in advance. It asks about all the questions that any TED clinician would want to know about. And by gathering that information, which basically the patient would fill it out, receive by email a PDF copy of that report that they could bring into their clinician, or they can email it to the office. It can streamline greatly the information gathering. At any time saved with the information gathering with the medical history can go towards discussion to answer all your questions. And it is important that you share with the clinician, which the questionnaire does ask about, any particular concerns you may have. So it's important that you share with the doctor anything you're worried about, anything you're concerned about, so they have the opportunity to answer that. Peter?
No, I agree with that. And in terms of what Betsy's experiencing, sort of feeling rushed, keep in mind it is the most complex disease that we see in our practice. So whenever, someone's running a busy practice, it will be a bit of a speed bump when they're encountering a thyroid eye disease patient. So some of the tips I would offer to patients is, as soon as you get in the room, whether you're speaking to the technician or ultimately with the doctor, just let it be known right up front as what your goals are for that visit. That may be different from what your complaint is. Like you've talked about double vision. We want to have that worked up, but someone's going to say, my goal is to say, am I a candidate for surgery right now? Or what are we going to do about that? So that's very clear. So you're not going to leave that encounter without having some basic concerns, and have your top 2 or 3 concerns stated right up front, so they can frame their discussion around that, knowing that it's a limited amount of time. And there is a huge amount of data that we as clinicians must gather, and you may only be experiencing your own symptom. It could be the double vision, but we're interested in all other aspects of the eye and all the other ways that thyroid eye disease can be impacting your visual system. and even just systemic systems. So there's a lot that we need to cover. So I think our questionnaire can really help streamline that.
Yeah, I'm going to see if I can share the image that you all had uh, sent me earlier today. Let's see if that shows up. Is that showing up on the screen now?
No.
No.
Not, but
Oh,
yeah,
There
there
it
it is.
is. There it
Okay.
is.
Yeah. Do you want to, do either of you want to take this opportunity to sort of talk us through this, or should people take a screenshot of this, or how
A
should we look at
screenshot's
this?
a good idea, and also the screenshot will save the QR code that's a link to the questionnaire. But basically, this explores the full scope of information that your TED clinician will want to know about. You may have very few symptoms, a very simple history, or you may have a lot of symptoms and a very extensive history with prior surgeries, prior treatment with biologics. And for every symptom you report, there's a lot of follow-up questions that need to be asked about, like which eye and how long's it been going on? Is it getting worse? How severe is it? And so this branching logic questionnaire allows you to explore further any positive responses, but it does include things like how the thyroid eye disease is impacting your life and what's your thyroid status. I mean, that's a confusing area, and I'll only digress for a moment, that people get very confused about the thyroid status, thinking, oh, well, you've got normal thyroid function or low thyroid function, so it can't be thyroid eye disease, which is not the case. So I just wanted to put that out there, that while most patients with thyroid eye disease have an overactive thyroid, maybe 10 to 15% of patients have a normal thyroid state, or their euthyroid, and maybe 3 to 5% have been reported to have an underactive thyroid. So that's very confusing to many patients and clinicians, thinking that if you don't have Graves' disease, it's not thyroid eye disease. And then there's a lot of other things we need to know about. If you're a smoker, if you're an active smoker, it does increase the chance of more aggressive disease. Important to get patients to stop smoking, and it's useful to have old photographs and prior records. You raised an excellent point about communication and coordination between different clinicians, and that is a problem. I mean, I know that Peter and I always send out a letter to the other doctors, like the endocrinologist and the primary care physician, but the others are not always very good about sending their notes to us. So we don't always know what's going on with the patient's thyroid function, general medical status, and it ends up, unfortunately, conveyed to us via the patient.
Yeah, secondhand, and it's a bit of medical telephone, which, as you know, then things can get blurry.
I would even, yeah, please.
I was really impressed with this form, and it points out how not every oculoplastics person is the same when they're approaching TED patients. So it's clear that people on this call are very committed to this disease, understanding it from, the past medical history, symptoms, all the way to treatment and surgeries. And so sort of going back to the initial Betsy's comment before about sort of trying to find the right person, most TED or most oculoplastics people aren't going to have you fill out this questionnaire beforehand. So it does. There are different. There's going to be different attention. There's going to be different attention to detail to our specific concerns with TED. So I really like this. I thought it showed a true commitment to understanding people with TED. So I'm going to just stop the share here. But if you want in the audience, please screenshot this in the next few seconds. And then there's a QR code. And Dr. Weinberg, if someone clicks on the QR code, I did it briefly today, it takes you to a questionnaire. If someone were to complete that questionnaire, would they would have access to a PDF of the responses?
Yes, at the very end, it asks you what your email address is, basically
Okay.
where you want the report sent, and then you will get an email that will provide a copy or a link to the PDF report. In addition, there's also a satisfaction questionnaire, because we'd love to know what you thought of it. Did you think it was easy, difficult? Would you be willing to do it again? But the PDF report you can download, you can print it out, you could, if you wanted to forward it to your doctor, you could.
So it's just
So-
something to be a great
Yeah.
tool to have right when you go into your initial visit. You can say, oh, here's some information, whether your doctor is asking those questions or not, will help streamline that visit, because you'll have a lot of data available.
What percent or proportion of your patients that have TED come to you with that as a diagnosis, and how often, in contrast, are people coming to you and then you are the one that makes the diagnosis?
Peter?
I would say most of our patients have it. The diagnosis is most of mine. Occasionally, I'm making it for the first time, because patients may present just with a prominent eye, or they may present with tearing, but other clinicians, prior to the patient seeing me, will have made that diagnosis. But occasionally we're making it primarily. We're both subspecialists, so the diagnosis is usually made prior to their encounter with us.
It's worth mentioning that with direct-to-consumer marketing now, you've got all these drugs being advertised on TV, and it's interesting to see how many patients come in on their own after having seen a Tepezza commercial, wondering if they have thyroid eye disease. So it does bring in more patients on their own. But I would say most patients come in with either a diagnosis of thyroid eye disease or suspected thyroid eye disease from a colleague.
Yeah, interesting how the direct-to-consumer things actually ends up in your doorstep sometimes.
Yeah.
Betsy and Joe, this is going to be a question I think everyone can answer, but I wanted to start with you, and it hits on some things before. These are all connected in the patient visit, but what would you consider the most common communication breakdowns that you've had? And then we can talk about ways to overcome those with you and your healthcare team. Betsy, maybe we start with you.
Communication breakdowns. Well, I'm not entirely sure how to answer that question. Because in part because I've had TED for a year. And I've been a user of my chart, of my online or my electronic medical chart, to try to keep my endocrinologist and oculoplastic surgeon aware of what's going on. They, maybe only go to their electronic communication once a week, but that has been a helpful tool for me. I did go on to Tepezza for for 3 doses. I suffered side effects that were impacting me a lot. And I think I would say a breakdown is in the minimization of kind of how my life is impacted. And just, trying to have my doctors understand, that it's impacting my ability to drive or my work, things like that. And just, I know that it's a complex disease, and I know that there aren't cures, but I also don't want to be gaslit, and to have just sort of say, well, your clinical activity score isn't very high. It's like you're really not that bad. And I've had a doctor tell me, 2 doctors tell me, like, oh, well, you can wear an eye patch to drive. And like, that is not my goal. I want to be able to use two eyes and be able
Yeah.
to do things safely. So
Mhm.
yeah, I don't know if that's exactly answering the question, but I try to do my best to communicate what's happening when I had like a return of all my symptoms after going off Tepezza. I want them to know that like as quickly as possible and see like,
Right.
what am I to do now? And what are my options? Yeah.
Yeah. I mean, I know this from conversation with you. You in particular have experienced sort of a minimization of your symptoms. They're just not listening to the quality of life changes that you're experiencing. And maybe the doctors can talk in a minute about what, if there've been quality of life studies and comparing it to other diseases. I'm sure there have been. Joe, how about you? Have you had any trouble communicating between your healthcare providers?
No, I have not. And Betsy with the eye patch in one eye, I hope I don't drive like Mr. Magoo, where he just caused all the accidents, but he was never hurt in anything. Um, Very honestly, my breakdown in communication is on me. And I think part of
Mm,
what I've done is, as I said before, a team of the oculoplastic surgeon and so forth. But also on my team, I have an advocate that's my lady of the last 21 years. She comes with me to every appointment. And one of the things that happens is, as an adult with ADD, the doctor will say something and I will go off someplace else and they'll continue talking. And I've missed all the valuable information they were attempting to give me.
mm,
And she comes and she's great, writes down, has the computer with her and takes everything down. And if you can have one of those, I think it's great because it then gives you time when we come back home, we can talk about what was said, what was,
right,
go back
right.
over it. We're in a very calm situation. If not, we're like, okay, we've only got 15 minutes and we
Right,
need to get
right.
this done right away. And so I think I have been very fortunate with the doctors I've been dealing with that they have communicated in an incredible fashion to me.
Mm,
And it's more on me. And
mm,
not that I don't ask the right questions, and I've been getting better. I tell them sometimes like, okay, I don't understand that term, and I think it's important as a patient that if you're going to be in be in that situation with Ted, like ask the doc, dumb it down for me, act like I'm a
mm,
5-year-old and tell me what that means
yeah.
because I know it. There's like, oh, well, I don't want to sound like an idiot. Well, if you don't sound like an idiot, but then you don't know really what they were talking about or what they were trying to communicate to you, that's not good either.
Right. Yeah, I mean, this is in contrast to something like a cancer center where you sort of get comprehensive approach. You'll have a nurse and a doctor and a team and a clinical manager, and everyone's sort of checking in and quarterbacking this. This is very much, I found, on the patient to coordinate everything, as you said. Um, and that means getting records and being organized and making sure the other people have your MRI results and get your updated labs and almost helping to facilitate communication between the different parties, which is not always as intuitive. And I say this as both a physician and a patient. There was a time not that long ago, I'm sure Dr. Rubin and Dr. Weinberg remember, where you would just get a phone call quite frequently about a patient. And man, you'd get about more done in that 2-minute call than, countless of letters and emails and back and forth. And that doesn't happen as much anymore. So it is a lot of electronic communication. And you hope that you're sort of navigating it the best way. It's not always clear, though, as a patient that that's happening. And I think I'm not always clear that my patients are getting through the system as well because of that. Dr. Rubin or Weinberg, are you able to comment on any of those things we discussed?
Sure. I sense there's a lot of frustration. I think a lot of it has to do with patients not being fully educated regarding the nature of their disease, what the therapeutic options are, and let's just take like double vision because you know
Mm-hmm. Yeah.
all you guys seem to have that. uh, that we know, like, to cure double vision, you either have to quiet down the disease, or ultimately, once stable, then we could potentially do surgery, or maybe once stabilized, the double vision will go away. But as double vision worsens, unless there's some sort of stability, we cannot do like an immediate intervention to kind of fully reverse that, despite everyone's motivation. So I think we have to kind of put things in perspective as when is the appropriate time to intervene, what the interventions may be, whether it be prisms in the glasses, occlusion, or ultimately surgery, or biologic or other therapies. And once the patients sort of have that in perspective, they can understand, we hear you, but we have to kind of wait for the appropriate timing. And then they have a better understanding of what the interventions might be, the timing of it. Then it may sort of ease their anxiety. But at the same time, I think that they can be helped tremendously, much more than we can help them, is by communicating with peers with that patient peers with the condition. How have you dealt with driving with one eye? We're not, as oculoplastic surgeons, we're not experts in that. I mean, hopefully, like, someone being monocular is a temporary condition in the setting of thyroid eye disease. How can we get them through those, that challenge? And I can't teach them as well as a fellow patient who's been on that journey. And so having them connected with an organization like this, it would be invaluable and can provide many, many more productive tips than the oculoplastic surgeon can offer.
Do you incorporate something like TEDCO in your patient information when you have patients with a new diagnosis?
TEDCO
Yes,
as
we
in
offer.
TED Community Organization.
Yeah, you do. It's great. Yeah. I hope that is something, because I agree with you completely. I think even just psychologically, and it's something we're going to address in the second hour today, but having a community to not just like get tricks, and there are a lot of tips that are helpful, I agree with you, but just sort of the shared history can be quite important.
A
I want
couple
to
of
touch on,
follow-up.
yeah, please go ahead, Dr. Weinberg.
A couple of follow-up things. Joe, you're in a fortunate situation where you go to Kaiser and probably most or all of your doctors are in the same system and the same electronic medical record. So everybody has access to one another's notes, and similar for many hospital-based physicians. For those of us in private practice, and there are many, we don't have such immediate access, and
Right.
communication is more of a challenge. It can be tough to get everyone on the same page. We all have to be diligent about communicating with one another.
Yeah. Good point. And that the oculoplastic surgeon and the ophthalmologist are in the same office,
Right.
in the same building. And so it's easy for them, and they can talk, and I feel good because my oculoplastic surgeon says, well, I've talked to this person and I've talked to that person. And so I feel like, okay, they've really addressed my issue, versus like, oh, I'm going to have to get around and call your other doctor. It's like, no, they've already done that. So you're right. I am very fortunate in that sense.
Betsy, you raised some very good points about doctors either not taking the time to explain things, or explain things in language that makes sense. If they're using a lot of technical verbiage, that's not very helpful. And so you have to meet in a place where the patient understands what you're talking about, and you're able to answer it in plain language. On top of that, clinicians need to really pay attention to the lifestyle impact of these things, and be empathetic. As Peter said, it can be challenging to provide the fixes in as short of a time period as possible. Like with the double vision, which is a good one, you have to quiet things down immunologically before you can undertake more definitive treatments. So you can do a prism or a patch, as you're using, Joe, but in terms of something more definitive like eye muscle surgery, it may take a while, or and that's often been a challenge. The waiting for the patient, the waiting till you can get to something more definitive, the waiting for this to run its course, which is why certain drugs like Tepezza have been helpful. Besides not suppressing immune system function, immunosuppressing people, it does speed up the course in terms of quieting things down faster, and may allow you to intervene with certain therapeutic interventions sooner than later.
Another thing to add is that since David and I have been at this for more than 3 decades, we can tell you that at the end of the day, most of our thyroid patients, quiet down and go on to very productive lives. And it's not like dealing with other diseases that can be more blinding or something that life-threatening, that most people emerge from this, intact and almost fully rehabilitated. And people should go in with that expectation. The time frame may take a while, but just know that you'll emerge, intact and quite functional.
Right. And I think one of the other things is this particular disease, it manifests itself in so many different ways. I mean, I have no eye pain, I have no redness, I have the double vision. And so as human beings, my background in psychology is that we want answers. And it's very difficult when you have this autoimmune disease that there are no real answers that you can, why did I happen? Why did this happen? It's like, well, we don't know. I mean, and I hope at some point, as the research continues, they do more. But I think that's one of the hard things psychologically for a lot of people with TED, to accept that they see all these other diseases where, okay, you have this, let's give you this intervention and we should cure you. And that's not happening with a lot of the TED patients.
And one thing, I'm encouraged, Dr. Rubin, to hear what you said, because I have yet to leave a doctor's office with my doctor saying, this will run its course and you will be okay. Like you might need surgery, or maybe your symptoms will go away. Like maybe there's a slim possibility of that happening. I don't know. I won't hold my breath, but like my doctor has yet to say, like, you are going to come out of this on the other side. Like it will resolve. It's not going to be forever. It is autoimmune. It could come back, but you're not going to live this way for the rest of your life every day with, this crummy double vision. And I think it was actually Nathaniel who said, like, we have to keep the faith that we're going to get on the other side of this. But Nathaniel was the first doctor who said that to me, and none of my doctors said that to me. So,
it means more coming from Dr. Rubin than it does from me.
I think, Betsy, one of the other things that I've been totally pleased with Kaiser, but one of the other things I think is that for the physicians to ask you about your emotional well-being related to the disease, because it can impact people in very different ways. I was 74 when I was diagnosed with TED. So it wasn't like I'm out there dating, doing all kinds of stuff. I was retired and so forth. And I think that's something just emotionally. How are you dealing with stuff, Joe? Would have been a question and a sort of an intervention that would have been a benefit to me.
Yeah, that's a really good point, Joe. It's going to be the highlight of what we're talking about the second half, the psychological manifestations of this disease, and it was touched upon last night too. And if you go back to the slide that we had up before and all the things to think about, you're right. The psychological aspects are important there too. It's daunting for me as a patient to have all those thoughts in my head and be kind of depressive about it, and know that the person has 15 minutes to have that conversation with me. And I know that's hard for the doctors too, because I know what their clinic schedule looks like, and it's it's not just me on their schedule. And I think that there's nuance to it, but I know we're also supposed to get to a Q&A. So I guess before we get to that, is there any final points? And it can relate to anything we've talked about, even including sort of like touching upon the most important things in your visit, but we could expand it to second opinions or even like portal communication ways to maximize that. But is there any final thoughts before we get to the Q&A that people would like to share?
I guess the only thing I would say is that, with TED, you're going to be different after that. I mean, my oculoplastic surgeon was very good saying, your eyes are not going to be like they were before. And that was good. But the reality of it is every day is different. Everything changes. And so it's, the old Joni Mitchell song, there's something lost and something gained in living every day. And I think for TED patients, what we need to focus on is, what did we gain today? Did we gain more knowledge about our disease versus what we lost? Because if we focus on what we lost with this disease, we are going to be unhappy. That's a given.
Yeah.
One thing I would add is that many patients come in with a major change in their external appearance, and we're seeing them for the first time, and they're normal to us. And it'd be useful if patients came in with a photograph. This is what I look like before TED. And they're saying this is sort of our endpoint. And you then once you see that contrast, you could say, wow, the clinician could be much more empathetic, saying, wow, what you've been through. I can see, you can be much more empathetic and compassionate by seeing what they've gone through. So sharing those images would be quite helpful, and also gives you an idea of where you're trying to help return that patient to as they're fully restored.
Good point.
Joe,
I was always told that I have a face for radio, so I was never thinking about, that I get bad, worse looking, because I didn't know if that was a possibility or not. So,
Joe, you raised a good point, and I was thinking about that before, about the conversation, will your eyes ever be the way they were before? And I think it depends. I didn't want to be depressing or negative. I wanted to be to give hope. And I think Peter provides the hope that in his comments that you will get through this and we will get you functional and seeing better, is feeling better. But it is true that if you have more severe involvement by the thyroid eye disease, you may not get back to where you were before. So like with double vision, the goal is going to be, in bad cases of double vision, to get you seeing single straight ahead, but you may still see double when looking off to the sides. And the goal may, in those cases, be just to get you more functional. And I think it depends on what we're talking about. If you're talking about exophthalmos with bulging eyes, we can get the eyes back to a more normal position. If it's eyelid retraction, we can get the eyelids back to a normal position, and we can treat dryness of the eyes. But double vision, that can be tough. You may never fully eliminate the double vision, but you can get people more functional with single vision in the most important fields of gaze, like straight ahead and down.
Well, thank you. Thank you all. Shaylee, I think we're going to have you take over with the Q&A if you are, yep, you're online. Perfect.
Yes. Thank you so much, everyone, for sharing all of your experiences. It's been really a great time, and I'm honored to learn from you all and present some of the questions that we got during the talk. One thing I wanted to say before we jump into the questions is some people were wondering about the questionnaire that was mentioned earlier. Christine mentioned that the TED Community Organization website has a research and resources tab where there's the questionnaire linked there. And there's also a link to that page in the chat.
Great.
For one of our first questions for the panel, any suggestions for patients who might live in rural areas with limited access to doctors, who might be considered thyroid eye disease specialists, especially with insurance being a limiting factor in access to doctors outside of specific areas?
The only thing that I can think of really is if you don't have access to seeing a TED specialist face to faces, there are always the possibility of teleconsults, telehealth visits in conjunction with seeing a local eye physician. So that may allow a patient to see a TED specialist when face to face is not possible.
Okay, great. Does anyone have experience following up with TED specialists with via virtual appointments, or Joe or Betsy?
My encounters have all been with my thyroid eye disease specialist have been in person in order for them to do the appropriate testing and test eye pressure and so on. Endocrinologists are almost always virtual appointments, and we review blood work, but and discuss what's going on. But yeah, with my TED specialists, it's all been in person.
Mine have been in person as well as the outside provider. I went out, flew out to California to see them, and that was an in-person visit as well.
I think face to face is always the best. We got more experience with virtual during the pandemic when that was really all we could do for a period of time. But face to face is the best, as Betsy and Joe said, to be able to do a number of measurements. And there's a lot that we can't do virtually.
Thank you. Thanks for sharing all of that. Another question we had was, how do doctors counsel patients about the decision whether to have surgical intervention such as thyroidectomy or strabismus surgery? And is strabismus surgery always necessary if someone has symptoms such as restricted eye movements?
Peter?
Strabismus surgery is not always necessary. I think, as David mentioned, even with restricted eye movements, you're not going to necessarily improve all of the wide range of movements, but you're trying to lock in single binocular vision in functional fields of gaze, straight ahead and like looking down, and patients learn to adapt around that. So it's not necessarily a full restoration, but could be a full functional restoration in terms of with other adaptive movements that patients have. And that's something which you need to review, with your TED provider. Every case is different.
Thank you. And then a question from Christine. What can we do or what can TED Community Organization do to better educate the community about thyroid eye disease to best complement the care that they get from their physician?
Well, I'll take a stab at that. I think that having like a patient buddy that our patients may have, that they can connect with the community. And because thyroid eye disease is so diverse, maybe, we as providers can kind of help label that person as like whether it's just a predominantly double vision, predominantly exophthalmos, what other issues may be, so they can be connected with somebody who is somewhat clinically matched to their condition and that is further along. And I think that could be invaluable. But given the diversity of TED presentations, you want to make sure they're matched up with an appropriate peer.
Yeah. One thing I would say, when I first became part of the TED community, I was actually matched with Nathaniel and had the great opportunity to talk to him. And it's one of those, unless you have the disease, it's hard for people to understand the disease. And he was experiencing the double vision at the time and taking Tepezza. And we had some Zoom calls together, FaceTime calls, and it was incredibly beneficial to me to, realize, because you can talk to other people, but other people don't know about thyroid eye disease. I never knew anything about it. I'd never heard of it until I got it.
Yeah.
And to talk to someone who's experiencing the same thing is invaluable.
Great.
Great. Thank you so much for sharing that, Joe. And I think that's a great idea for all thyroid eye disease patients or for our organization. One more question here. Is the primary care physician and or endocrinologist usually involved in thyroid eye disease? Is it unusual to request that he or she become part of the team?
I think they should always be part of the team. We all play our different roles. The ophthalmologist, the oculoplastic surgeon, the endocrinologist, the primary care physician, and I think we all play important roles, but need to be communicating with one another in that regard.
And we got one more question. What resources are available to prevent blindness or other visual impairments? I think it's kind of what we touched upon throughout the talk, but if any further thoughts?
Blindness or visual impairments, if we're talking about what's most common, it probably would be like dry eye syndrome. And dry eyes are probably the most common problem that causes eye discomfort and blurry vision that comes and goes. And it's important to be adequately lubricating your eyes. We talked about double vision as a visual impairment. In terms of blindness, actually, that's quite rare these days. There are adequate treatments. Typically, we're thinking about compressive optic neuropathy, and that is said to occur in about 5% of patients. We have a variety of treatments, systemic steroids, Tepezza, and orbital decompression surgery. So these treatments are virtually always effective. I think it's rare that anyone permanently loses vision despite these interventions. So fortunately, as long as the patient is getting in a timely fashion and being followed closely, few, if any, patients should end up blind from this condition these days.
Thank you so much. And then we have a question for our patient panelists. One of our attendees shared their experience about their recent diagnosis with thyroid eye disease and just starting off on Tepezza and waiting for some more results. He's curious, he or she's curious, how long was your treatment with Tepezza and how has it improved your situation or not? And thank you so much for sharing your experience.
Nathaniel, you may want to go for that question.
Yeah, well, I think all of us are different. I know Joe and Betsy and my histories, and they're very different in terms of how we've been managed and how we've responded to treatment. So there isn't a simple answer to that question. I think and it would be unfair to generalize with that. I mean, one thing I'm always aware of is that as a community, we have a lot of wisdom through experience of the disease, but it's a bit, in terms of medical world, we don't really see the forest for the trees the way Dr. Rubin and Dr. Weinberg do. And so my advice is always to really get to someone who has a broad understanding of this disease, and can listen to your history and place your concerns within sort of a overall disease severity framework, and really tailor the right treatment. Tepezza isn't the right treatment for everyone. It is the right treatment for a lot of people, and same could be said for surgery and steroids and IL-6 inhibitors, et cetera. And so I think in today's world of internet, do your own research, it's dangerous to sort of think we maybe have all the answers. I think I put a lot of faith here in the sort of the generational wisdom of the TED specialists. And hopefully one thing that our organization can do is help guide people to those folks who can help you out.
Excellent.
I went through, oh, I'm sorry, Doc, go.
No, up to you.
I have, previous to starting on Tepezza, I had some hearing loss. And so there was always a concern about permanent hearing loss related to that. And I went out, and the doctor that I talked, Dr. Douglas, said that with his patients, he did 6 weeks apart versus a normal protocol of the infusions 3 weeks apart. And then between each infusion, I had a hearing test to see if there was any loss. And I got through 6 infusions. And then after the 6th one, I went in hearing, and I was losing some additional hearing. So I decided at that point, okay, I'm going to stop. I'd rather still be able to hear. And if I start, worst case scenario, I have to wear an eye patch the rest of my life, I'll do it. The reaction, if you go online and look in the blogs about Tepezza, don't, because if you do, you'll just want to commit suicide at some point, because everybody's got a bad story about it. And it's, and it is a medication that has a lot of side effects and so forth. But it brought down my bulging eyes significantly, but it impact what's in on my double vision whatsoever. And so, but again, as Nathaniel was saying, it's like my one example, and then that doesn't, and then you have to think of all the other medications I'm on for different things, my age, all those kinds of factors. And so to extrapolate out from, oh, Joe's experience is this, so therefore it will be my experience, is totally wrong.
And I would just add, the Tepezza specifically is a relatively new drug, and the studies, there are updated studies from the time that they began administering this drug to show the recurrence of symptoms. And rather than blogs, I would say get on PubMed and look at the articles that are available, that are, published articles and abstracts to help inform you of what's the latest research on Tepezza and its effectiveness for certain symptoms. And then talk to your doctor about it. And, ask them to opine on like what you've read and what you understand. And that helps help you make an informed decision.
I think we're at the top of the hour here. It's interesting you were saying that, Betsy, and I'm like, that could stimulate a whole other round of discussion, which I would be eager to hear everyone's opinion on. But I think for the sake of staying on time, we should wrap it up. Shaylee, are there any other burning questions we should hit before the intermission and going into the second session?
No, I do not think so. I think we hit a lot of the questions in our chat today. Thank you so much.
Well, I want to thank the panelists and all of you for generously giving your time and your honest answers and your vulnerability to both Betsy and Joe, and your expertise, Dr. Weinberg and Dr. Rubin. We're really grateful for everyone, and this is a special community, and I'm grateful for everyone. Thank you.
Happy
Thank
to
you,
be
Nathaniel.
here and
Thank you.
nice to meet you guys.
Thank you
Thank you for the opportunity.
Thank you.
for your wisdom.